Hi, my name is Dr. Heliana Ramirez. I'm Director of the CARE TA Center with the Crisis and Recovery Enhancement Training and Technical Assistance Center. Welcome to this presentation about suicide prevention and postvention. I'm thrilled that you've joined us at our conference, Listening, Learning, and Leading, Anti-Racism and the California Crisis Continuum of Care. We have many people who are going to be at our conference who come from a behavioral health background. They are peer specialists, psychologists, social workers, marriage and family therapists, psychiatric nurses. These are people who oftentimes will have quite a bit of expertise in terms of suicide prevention and crisis care. We're also intentionally inviting our partners from the community, from LGBT community centers to faith leaders and people who work in food bank programs and services that provide housing and homelessness services. Many of these people might be somewhat new to the crisis continuum of care. So if that's the case for you, this training is for you. This training is going to help to provide a little bit of grounding around suicide prevention and crisis continuum of care. So as I pull up the slides, I'll just share with you that I am a social worker by profession. And I have been doing suicide prevention for a number of years now. It is a topic that I feel very strongly about, and I'm honored to be able to share this information with you today. So quick disclaimer, we are funded by the Mental Health Services Act, administered through the California Department of Healthcare Services. And I work at the Center for Applied Research Solutions, CARS. While I am most grateful for the funding and the stewardship of this grant through DHCS and my employment at CARS, what I'm about to share, of course, does not necessarily reflect any of their opinions. CARE TA Center. As I mentioned, we are MHSA funded to provide training and technical assistance to the behavioral health county level agencies, as well as the 2 city jurisdictions in the state of California. We provide training and technical assistance regarding the crisis continuum of care and justice diversion. We're particularly interested in evidence-based practices, community-defined evidence, and engaging stakeholders and partners in strategically planning, implementing, and continuously evaluating our services. I am most honored to be part of a collaborative 5 agencies. CARS, as I mentioned, is where I work. We are the lead agencies on this project. And we work closely with RI International, National Association of Mental Illness, NAMI California chapter, C4 Innovations, the Research and Action Center at Impact Justice, and Stanford Sierra Youth and Families. We provide a variety of training and technical assistance ranging from virtual online webinars, distance learning events, as well as conferences like this conference. We also provide a variety of resources and tools that are on our website. Please check them out, from our resource library to our crisis continuum asset map, which I'll be sharing with you briefly in a few moments here. Feel free to connect with us through our newsletter and our social media accounts. You might also request training and technical assistance on our website. So briefly, what I'm going to be doing in this short training is talking a little bit about the crisis continuum of care in California. Then I'm going to share some evidence-based interventions for suicide prevention. And I will wrap up talking about culturally responsive, community-defined, and socially distanced suicide prevention with 4 communities that have elevated rates of suicide, those being veterans, lesbian, gay, bisexual, transgender, queer-identified people, LGBTQ, Indigenous communities, and middle-aged and older men. So briefly, suicidal crises are a time when a person's everyday coping strategies become overwhelmed, and the person becomes flooded with feelings that are so painful that they want them to stop. Oftentimes, people who survive a suicide attempt will say later that they actually had some ambivalence. So while they wanted the pain to stop that they were experiencing, they didn't necessarily want to die. They just wanted the pain to stop. That pain might be in the form of grief, sadness, loss of hope, rage, or shame. And it's important to note that we understand now from research with culturally diverse groups that the primary emotions that will oftentimes be associated with a suicide crisis are different across communities. And that's important because if we're always asking questions about a sense of depression, we might miss a risk of suicide if the primary feeling is one of shame, for example. Importantly, many of the models around suicide talk about a sense of feeling like people are a burden to others and they are disconnected from others. So oftentimes, some of the best interventions we can do to help people to get through or to prevent a suicidal crisis are providing access to resources that will get them through that time-limited period, whether it's a few minutes, a few hours, or even a couple of days when their coping strategies are overwhelmed, or I should say, and connecting them to community so that we can overcome that sense of thwarted community connection. So when we talk about a crisis continuum of care and looking at this from a systemic view, the CARE TA Center follows SAMHSA, the Substance Abuse Mental Health Services Administration, in the goal of helping people to recover from behavioral health crises like suicidal crises in the community. The more that we can keep people outside of institutions like emergency rooms, inpatient locked psychiatric facilities, and incarcerated facilities, unless they absolutely have to go there, the better. Why? Because when people are able to receive support in the community, be it in their home, in their neighborhood, even at their school, people tend to be able to down-regulate, calm their central nervous system, recover the coping ability more quickly than when they're in an environment that's oftentimes very intense, like an emergency room or psychiatric facility or incarcerated facility. Not only do we tend to have better health outcomes when people are able to recover in the community, but it's also much less expensive and it's oftentimes more humane as well as culturally responsive. How do we do this, you might ask? Well, the best thing to do is to help people to de-escalate, to calm down in the community, help them to get through that intense moment, in part by making sure that we're maximizing the process and the flow and the communication between different systems along that crisis continuum of care. So here I'm about to show you an infographic that bridges the values of SAMHSA. That's that blue box on the bottom left-hand side of your screen. These are guiding values that have been created largely by people like psychologists and social workers and other people who are clinicians or researchers. On the right-hand side is a golden box of peer values. So these are values that have been created by people with lived experience of suicidal crises and our other mental health challenges. These are the values that these people say are really helpful to supporting people to recover from behavioral health crises. So this infographic is bringing both of these value systems together. We start off with a person-centered perspective, important because oftentimes it's easy to start talking about statistics and forget that we're talking about real people. The first circle is the person-centered circle. So this is when the person is of themselves. The next circle is community-based. And then the final circle are the institutional interventions. When we're able to help people to down-regulate or to calm and regain the ability to problem solve on their own, that's where they have the maximum personal autonomy because they get to decide whether or not when they feel really stressed out or really angry or really having a strong sense of shame, whether they want to go for a walk or pick up their favorite cat or listen to their favorite music. That's where they have the most autonomy to decide what they're going to do to help themselves feel better. If that's not enough, then they might have to go to that community level. This is where we have semi-autonomy because they're typically interacting with another person. And if that's not enough, that community level support, that's when we start to think about an institutional level support. That's where there's the least personal autonomy. So persons having a behavioral health crisis like suicidal feelings, perhaps the first thing they might do is to call a warm line or crisis line. And the person who answers that phone is going to help them determine whether or not they might be able to down-regulate and calm down and get stabilized by accessing peer support. Maybe it's through a peer-run crisis center, or maybe they need to call a mobile crisis team who will go to the person's house or school or other place in the community to help assess whether or not they'll be able to recover from that crisis in the community. Maybe they determine that the person needs to see a mental health provider on an outpatient basis, or maybe they need to access a brief psychiatric stabilization unit. These are oftentimes things like recliner chairs, where a person could go for 23 hours or less. And in fact, research shows us that in the right kind of calming environment, especially one that has peer specialists and is set up for a recovery moment that's based on autonomy and immediate care and hope and respect, oftentimes people can recover from these crises in 10 hours or less. But sometimes people do need that higher level of care, like an inpatient psychiatric hospitalization. Sometimes there might be a crime that's in progress, and people might call a mobile crisis or a crisis intervention team or co-response team. That's when there is law enforcement and a mental health provider who do a ride along together. It might be that the person, based on legal issues, might end up in jail or in prison, and then they would be interacting with a justice system forensics team. Wherever the person ends up, if they're in the community or an institutional level of care, it's really important that a few things follow them across this continuum of care. So one is a wellness recovery action plan. There's also the suicide safety plan and psychiatric advanced care directives. These are plans that the person writes when they are in their most stable moment that says, if they end up in a time of really intense emotional distress and they need help, where they'd prefer to access that help and what kind of help their preference would be. Ideally, if a person is moving along this crisis continuum of care at any point in time, these plans will follow them. And all of the people that they interact with along the way will institute this plan. And the reason why there are bidirectional arrows is because, again, that plan should be going with them in whichever direction. Additionally, the system of crisis care is most effective when assessments also follow the person across these different planes. So that when the person is here in themselves, they're constantly assessing, how am I doing today? Would it be helpful for me to call my best friend? Or would it be helpful for me to pick up that book that always makes me laugh and feel a little bit better? If the person is interacting with somebody at that community level, that person that they're interacting with is also constantly doing assessments to see whether or not the person is safe to stay here at the community level, or if they need a higher level of care. And if they go in for that higher level of care, there also should be regularly assessed to see when it's time for them to go back down to a lower level of care. Additionally, communication is really important across these systems. So for example, if this person has reached out to their mental health provider by phone, the mental health provider determines that really they need a higher level of care. We want to make sure that any referral that mental health provider makes does not end up in the person sitting in a waiting area for hours and hours on end. We really want there to be communication, warm handoffs between systems of care along this continuum so people don't get stuck waiting for too long. So you might say, well, Ramirez, those icons look great, but I don't have those in my county. If you're in California, you just might. If you were to go to the CARE TA website, you would find this California County Crisis Continuum Asset Map. And you could select the county that you work in, either by clicking on the map, or you could select your county up here. And then you could select the kinds of programs that you're working for. And in the bottom of this box, all of the different programs that are available through the Mental Health Services Office of Accountability Transparency Suite would show up here that relate to crisis care and justice diversion. So for example, if you are in Orange County, San Mateo County, Kern, Lake, Sacramento, or Los Angeles County, did you know that you have your very own local crisis prevention hotlines? Or did you know if you're part of any of these counties that you actually have a crisis stabilization unit or suicide prevention programs in all of these different counties? It's a really important and exciting time in California for us to look at crisis continuum of care because there are so many great services that are available across our counties. So the first thing that's really important to do is to figure out what those local resources are and to have them on hand. The second thing that's really important to do is to start to institutionalize, that is, make regular suicide assessments. And in these slides, I'm going to share with you just a couple of very quick suicide assessments that anyone can do. You don't have to be a clinician to use these assessments. So the first one is the Ask Suicide Screening Toolkit, otherwise referred to as ASQ. There's also the Columbia Suicide Severity Rating Scale. Both of these screening tools are brief. As I said, anyone can use them, and they both have training programs that are online and just take them not very long to learn how to use them. What I'm showing you right now is the actual Columbia Suicide Severity Rating Scale. It only has 6 questions and it's color coded. So if the person says yes to question number 1, have you wished you were dead or wished you could go to sleep and not wake up? You would write yes or no. Then you ask, have you actually had any thoughts about killing yourself? Yes or no. And then it has directions. If the answer is yes to number 2, ask the person questions 3, 4, 5, and 6. If the answer to number 2 is no, go directly to number 6. Down here are the directions. If the person has said yes, it's important to seek behavioral health referrals. If the answer to 4, 5, or 6 is yes, it's important to seek immediate help. If you'd like to get trained or train your own staff on how to use this tool, there are free trainings that are online. The other screening tool is the Ask. This was created by the National Institute of Mental Health, and it was normed out. It was tested with young people. It's also validated for use with older adults too. But just like the last assessment, this is only got a few questions. There are 5 questions here, and then there are very clear directions about next steps. If the person says yes or no to different questions, what you should do. The most important piece here is that we ask the questions. One of the fallacies or one of the false beliefs that are out there is that if we ask people about suicide, it will put the thought in people's minds. The reality is, if people are already feeling overwhelmed to the point that they need the pain to stop, us asking whether or not they're having thoughts of suicide is not going to tip the scale. If anything, it's going to help us get them connected to care. So it's always important that we ask, and especially during 2020 and 2021, there are so many challenges, right? COVID-19, systemic racism, there's the drought in California, going back into the fire season. There are so many different things, the recession, right? All of these things can suddenly compound and add up so that people's regular coping strategies might be overwhelmed. With this Ask screening tool, there's even trainings that are around COVID-19 and suicide screening. So now I'm going to go briefly into some evidence-based practices for suicide prevention. For the sake of time, I'm going to go through these fairly quickly. If you'd like to request a longer training, please go to our Care TA Center website, and either you can watch some pre-recorded longer trainings on this topic, or you could request a training specifically for your team. It's really important to point out that asking people not to hurt themselves, otherwise known as no suicide contracts, do not work. In fact, they can have the adverse opposite effect of what we are intending. When we ask somebody, please promise me that you won't hurt yourself, it actually can disrupt our rapport with them. It makes them feel not that we care about them, but that we're more worried about either managing our own legal risk in a situation, or we just don't understand how much pain or discomfort they're in. Much better than a no suicide contract is setting up a safety plan. Safety plans are brief, evidence-based interventions that have been found extremely effective. In fact, one study that was looking at suicide prevention plans used with veterans in Veterans Affairs Hospital who were going into emergency rooms found that for those veterans who ended up in an emergency room following a suicide attempt, who were engaged in creating a suicide safety plan, there was a 50% reduction in a subsequent suicide attempt as compared to those veterans who ended up in an emergency room following a suicide attempt, but had no suicide safety plan done while they were in the emergency room. Suicide safety plans are most effective when they're done collaboratively. So that means that the provider, whether a licensed clinician or a staff person at an LGBT center, when that staff person does the safety plan with the client, that's when they tend to be most effective. When they're culturally responsive, when the client can say, you know what, in my culture, I prefer to do this or do that. I prefer to go to play backgammon versus I prefer to play video games with my buddies. Or I prefer to go to ballet folklorico performance, or I prefer to go to the club where I can dance it off. Engaging those culturally specific strategies, which typically our clients are going to be able to identify on their own, that is what tends to make the most effective suicide safety plans. Additionally, we want to create safety plans that are strengths-based, that reduce stigma, and maximize their connection to other people through social support. There are several safety plans that you can choose from, all free, all online. I've created the links here for you, so you can check out all of them. And importantly, they should be written in first-person language. So I will do this rather than Susie Q will do this. It's really important that the person that you're working with has the safety plan. It's really not, the ultimate end of the safety plan is not to sit in your clinical file. It's important to have a copy of it in your clinical file, but it's most important that the client have it because they're the ones that are going to need to use it. Here's an example of a safety plan that's really well researched by Stanley and colleagues. And you can see that, again, it's a simple form, only 6 questions. You start out asking the person, what are the warning signs that you might be heading into a difficult period? What thoughts, moods, situations, or behaviors might let you know that a crisis is developing? So people might say things like, you know what, when I start to have automatic thoughts that I'm just a loser, or when I start to have such feelings of overwhelm that I can't get out of bed in the morning, or when I feel so much shame that I don't want to leave my house, or I'm so scared of other people that I can't go to the grocery store. These might be some of the kinds of examples that people might put into this first step. So importantly, we need to identify in order to start the safety plan. So then the question is, all right, if you're having any of these experiences, what kinds of internal coping strategies, that is, what are the things you can do to help take your mind off of the problem without contacting another person? These might be relaxation techniques, or doing a puzzle, or taking a walk, or things that the person might be able to do on their own. If that's not enough, then who are the people that you can contact, or the social settings that you could go to that would provide distraction? So these are people like a buddy that you could call up. You don't necessarily need to tell them that you're having a crisis, but you could call them and just talk about the recent game that was on TV, or maybe it's the favorite coffee shop that you might go to and just do some people watching. If that's not enough, then who are the people that you would actually reach out to that you can ask for help, that you could tell that you're having a hard time? It might be my favorite sister, or my neighbor, or a cousin, somebody else. And then almost second to last is, who are the professionals or agencies that if you need professional help, you would most like to reach out to? It's important to write their names, phone numbers, and any additional emergency contact information. It's important to identify where the local urgent care services or emergency services. And then finally, and this is extremely important, what can you do to make your environment safe? Also referred to as means restriction. In addition to safety planning, the other major evidence-based intervention for suicide prevention is to reduce access to things like guns, things like an oversupply of medications, because as I said in the beginning, suicidal crises are time limited. If we can separate a person from access to these lethal means, even by a couple of hours or a couple of days, that can and does save lives. So that's what we're writing down here in making this environment safe. Maybe the thing is I can give my guns to my neighbor who can keep them in her locked gun box. Or maybe I would separate the bullets from the gun. Or maybe I'm making sure that there is a gun lock on the gun. And I give the key to my partner. Additionally, maybe I'm searching my home to make sure that I'm getting rid of any unused, unnecessary medications so I don't have those lying around. This is another example of a safety plan that was created by nowmattersnow.org. And you can say that, again, there are very few questions that the person can fill out. On the other side, there's a whole bunch of examples of things that the person can do if they're having suicidal thoughts, or if they're having an actual active crisis moment, who they can call, and what things they can do to keep themselves safe. Importantly, in 2021, we've got a lot of apps now that people can put on their phones, whether they're iPhones or Androids. This is one example. This is called the Virtual Hope Box. And in the Virtual Hope Box, there are a variety of activities that the person can do to help themselves calm down and distract them from that crisis moment. So you see here, there are different kinds of puzzles, word search. There are also relaxation exercises like controlled breathing, muscle relaxation. You can also put in the Inspire Me link, favorite poems or inspirational quotes, coping tools, and other things that the person finds helpful to them. Here's a slide that talks about means restriction. Importantly, we know that, as I mentioned, doing things like putting a gun lock on guns, separating bullets from guns, keeping guns in a locked storage unit are really, really critical. Getting rid of unused medications, also really critical. Here are several different links that you can go to learn more about means restriction. So as I started out mentioning in the beginning of this presentation, there are some communities that have higher rates of suicide, such as veterans. We also see more recently, when we look at youth populations, increases of suicidal crises among Black females, followed by Hispanic males, and then gay, lesbian, bisexual, and transgender youth. This is from the 2017 Youth Risk Behavioral Health Survey. That was in terms of suicide plans. In terms of actual suicide attempts, we continue to see from that same period of time, Black females, followed by Black males, and then gay, lesbian, bisexual, and transgender youth. Importantly, when we're in the shelter-in-place orders, 1/3 of LGBTQ identified youth were sheltering at home with family who were unsupportive. And when that happens, there is an 8 times increase in suicide risk for those youth. Importantly, for you as a staff person or parent to know, just having one supportive person in an LGBTQ young person's life can reduce the risk of suicide by 30%. So just being an open and affirming adult who accepts them exactly the way they are can help to reduce the risk of suicide. Another example of this is using the proper pronouns for transgender young women and girls. So this is a person who is born in a body that has been assigned male at birth, so they're male genitalia when they're born, but the person grows up and says, actually internally they feel like a girl or a woman, and then they become a transgender girl or a transgender woman. Using the proper pronouns, she and her, that is suicide prevention. Or vice versa. If the person is born in a body that has female genitals, but they grow up feeling like a man or a boy, and they transition in any way to become a transgender boy or male, making sure that we use he and him pronouns, that is suicide prevention. So I mentioned briefly before that there are culturally specific ways to think about suicide prevention. It's important to think about the culturally specific suicide risk factors. So we see with these elevated risk of suicide among, for example, Latinx young women, that oftentimes there are tensions between the young women and their mothers or other people in their family who have very strong cultural values from the country of origin, the Latino country of origin, and then the American culture that the young woman is growing up in. And from those tension is when we tend to see higher rates of suicidal crisis. As I mentioned before, some communities, it's not a sense of depression that you see prior to suicidal crisis. It's instead a sense of shame. Chu and colleagues have found this when they did systemic reviews of the literature. There's quite a bit of research that's showing among Asian American Pacific Islander communities that there's more a sense of shame prior to a suicidal crisis than depression. So it's really important that we're assessing the proper things. We're assessing the proper feelings. We're looking out for the proper kinds of stressors that tend to relate to suicidal crises in different cultural communities. It's important that we're creating an intervention plan and a prevention plan that build on the existing strengths of the community, especially cultural strengths, and that affirms their history. And that we use culturally specific forms of artistic expression and healing. So whether it's using sweat lodges in indigenous communities or connecting people who have a strong affiliation to blues music or hip hop or other kinds of music, that we connect them to what makes them feel strongest and most validated from their own cultural experiences. It's also absolutely essential that we acknowledge historic and contemporary forms of trauma, and especially those senses of trauma that are tied to racism, sexism, homophobia, and transphobia. We know that there is an association between these kinds of social stressors and elevated physical and mental health illnesses. And it's really, really important that we connect people to mental health care and recognize that when there's a lack of access to mental health care, that's when we start to see a pipeline to incarceration. And importantly, we want to help people of color, LGBTQ folks, people who are living with disabilities, unlearn the internalized, that is the accepted stigmas about themselves, and that we help to advocate for a system that is healthier. So rather than asking what's wrong with you, we ask what's happened to you. Rather than trying to keep people from killing themselves, from taking their own lives to stop the pain, we want to create a world that's worth staying alive and living in. And we can do that by working on these systemic and interpersonal biases. So important points to consider when you help clients create those safety plans. You want to think about diversity, whether it's in terms of age, race, ethnicity, sexual orientation, gender identity, religion and spirituality, or their veteran status. Want to think about where the person is living. If you live in a rural area, it might be harder to access resources than in an urban area. Want to think about the things that are activating stressors. So for veterans, for example, many veterans that I've worked with, depending on when they served and where they served, certain smells or sounds or can really bring up memories of their combat, for example. So it's important to identify what are those factors that can really bring up very quickly that memory of trauma and overwhelm the coping abilities. Just as important, however, is to think about the regulators, things that can help to calm that central nervous system. And that's what we put into the safety plan, both of those points that I just mentioned. Here's a great example of something that I've used with clients over and over again. It's the idea of a feelings thermometer. So when we think about the safety plan, we were hoping that people will start to think about using their safety plan when they're getting around here 4, 5, and 6. When they're okay, or this is hard, but I'm still in control. And certainly when I'm starting to get uncomfortable, that's when we start the safety plan. Safety plans are most effective when we start to regulate ourselves around this part. If we wait until we're exploding and out of control, that oftentimes is not when we're most effective in helping ourselves to calm down. So I talked to you about the Hope Box. There are additional apps where you can actually build your suicide safety plan into the phone, so you have it everywhere you go. My 3 app is another app that's about a suicide safety plan. And then there are a variety of alternative activities that people can do to help themselves down regulate or to calm down. And these things range from cold water. Maybe it's putting cold water on the face, taking a really cold shower, getting a bag of frozen peas, putting it on the back of the neck. We know that these things really actually do help people to calm down. But there are a variety of additional strategies that people can use. And I've put hyperlinks here in these slides so that you can go in and check them out yourself. The song Weightless by Marconi Union was actually created by neuroscientists and musicians who created a song that research has shown reduces stress and anxiety by 65%. It's really helpful to look at our thinking, to do cognitive behavioral kinds of interventions. So coming up with alternative thoughts to thought patterns that are self-defeating. So for example, this National Center for Post-Traumatic Stress Disorder through the Veterans Affairs Administration has created these worksheets that help us to think about more positive thoughts that help us to cope better, and more positive thoughts that move us from a place of feeling helpless to a place of control. So for example, the automatic thought that might be problematic over here is, I should be coping better. That might make people feel helpless, useless, or scared. Alternative thoughts might be, I got here today, so I'm coping a little bit. I'm talking to a friend, mentor, or counselor might help me cope better. Or most people who would have trouble in a situation like this. If we have that kind of alternative thought, we're more likely to feel less scared, more hopeful, less helpless. We might feel stronger, more capable, and open to getting support or help. Here's another app. This is psychological first aid. So this is especially good for you as a provider, especially if you are a non-clinician provider, not trained in behavioral health, but you work with people who tend to experience high levels of crisis. These are things that you can help people do in or immediately following a crisis to help them to regulate, to get stabilized. You can put this app on your phone. The Safe Place app is an app that was created by an African-American woman specifically for the Black community. So this is an app that talks about mental health stigma, and the experiences within Black communities, not just in terms of acceptance and stigma, but also in terms of the very distinct experiences with police violence. This is an intervention called Gunskins Cover Me Veterans, where veterans can go online and create a sticker with a picture of a family member, friend, or their favorite pet, and put that sticker on the firearm. So if they're in a moment of suicidal crisis and they pick up the firearm, they'll be able to look at that person or animal that they don't want to leave behind. And it turns out that this has been a very effective intervention for many veterans. For our LGBTQ youth and adults, it can be really important to connect with other people who can say the message, it can get better. And this website, It Gets Better, thousands and thousands of videos have been uploaded by everyday people to celebrities who talk about how they got through very tough moments, oftentimes in high school or junior high. And because they were able to hang in there, life eventually did get better. And then finally, in conclusion, there are a variety of references. If you are interested in learning more information about suicide prevention or suicidality, please do check out these references. I sincerely appreciate you sitting through this training here. If you have questions, please do get in touch with us. Send us an email to the Care TA Center. Contact us by phone. Visit our website where you can connect to our newsletter. You can also check out our social media handles, and please do enter a TA request. We would be most happy to answer any questions that you might have and assess whether or not your TA request is something that we might be able to respond to at the Care TA Center. Finally, I just really want to thank you for the critical work that you do. And please know that you can help people to get through suicidal crises. And we are all better as a society because of the important work that you do in the field. Thank you so much.